Hello, welcome to eCancer TV. My name is Neal Shore. I'm the medical director of Carolina Urologic Research Center in South Carolina. We're here today at ASCO 2018 in Chicago. It's a great privilege for me to interview my good friend and esteemed colleague, Professor Karim Fizazi from Gustave Roussy in Paris, France. It was a year ago, almost to the day, that Karim spoke at the plenary session here and revealed as the principal investigator the trial known as the Latitude, which has now completely revamped how we look at patients with high-volume, newly diagnosed metastatic prostate cancer. It's now been incorporated and approved by both FDA and EMA, so really a remarkable achievement, Karim. But we're here today for me to ask you some questions of what's happened in a year's time. Not so much on Latitude. We have a separate group that's going to discuss your work and your outstanding achievement. But I wanted to review with you today some of the work that you've been going through in terms of looking at other molecular pathways beyond the traditional androgen receptor axis, particularly in our patients with advanced prostate cancer or castration-resistant prostate cancer, for lack of a better terminology. So maybe we'll start with the really sexy topic of the immuno-oncologic agents known as the checkpoint inhibitors. What's some of the work that you've been doing and your thoughts on this pathway?
Right, and thank you for asking me this question. Obviously, immunotherapy is a big thing in oncology at the moment, and for some years we thought that perhaps prostate cancer could be an exception, unfortunately. Although we knew from the past that CTLA-4 targeting can work, at least on the individual level in these men, with very long-lasting complete responses seen with ipilimumab, either alone or in combination with local radiation targeted bone lesion. But you know, the first experiences that were reported with PD-1 or PD-L1 inhibitors in prostate were not that good. And that was based on a very limited number of patients. So there was no big development originally in the first part of the 2010s. And then out of a sudden, we had two reports 2 years ago in patients progressing after enzalutamide, indicating that pembrolizumab seems to work, with about, say, 20% of patients responding, and sometimes responding tremendously. Actually, some of these patients had MSI-high cancers, and so this is something we know more and more now, that these patients, regardless of their primary cancer, seem really to benefit from checkpoint inhibitors, but actually not all. Other patients with prostate cancer do benefit from these drugs. So the big question now is how to identify those patients, but also how to make sure that more patients can benefit from immunotherapy, not just, say, 20% of them. So one big idea regarding the second question is whether combination can make a difference. So there are at least 2 trials trying to marry their drugs with other compounds. And I'm talking about PD-1 inhibition together with either chemotherapy, enzalutamide, or PARP inhibitors, depending on, of course, what the patient has received, and hopefully in the future, depending on his own cancer biology. So these trials are obviously not mature. We don't know the data, but they're rapidly occurring patients, and hopefully we will have the data soon. But I think the concept is really interesting because in some models, you are really able to boost the immune effect of these agents just by combining with something else. And again, that can be chemotherapy, AR targeting, PARP inhibitor, either just thanks to the activity of a drug, PARP inhibitors, or also perhaps because we might select patients with DNA repair defect genes, and perhaps those patients are also more likely to benefit from immunotherapy, not only PARP inhibition.
Yeah, it's a great point. I think you're referencing some of the really nice work done by Julie Graf in that small population, but who really responded remarkably, who had progressed through multiple lines of therapy, and then they received some pembrolizumab. Correct. And I think at this meeting, she's reporting on some additional follow-up. But I think you really touch on the issue of taking a tumor that might be cold immunologically and perhaps changing it to become more receptive to a checkpoint inhibitor. Could you maybe expound upon that for our colleagues, how that could happen?
Well, actually, it's really hypothesis at the moment, to be honest. I mean, it's true that in most prostate cancers, you don't see too many lymphocytes around the tumor, although there are exceptions, obviously. So the hope is that really using a drug will generate more, how can I call that, more activity, in simple words, that will attract the lymphocytes around the tumor, and then the lymphocytes will be able to kill cancer cells. So there are several models where that seems to be true. All these drugs work totally different ways. But again, big part of this work is really hypothesis. We may learn actually more than we expect, and perhaps all our hypotheses are not the right one, and we will understand afterwards that these drugs do not exactly work the way we were expecting them to be. So, for example, we don't really know whether the story of patients benefiting just because they had seen enzalutamide is really due to enzalutamide or to the effects enzalutamide is doing to VAR or to something else. So this is really a brand new field. Probably many things to discover, but it's really exciting because at least at the individual level, again, we do see responses. And sometimes, as you said, in patients who have already exhausted everything. So that's really good for patients.
So you touched on, and I think we began by noting the use of the checkpoint inhibitors as having sort of in a monotherapy approach after multiple lines of traditional approved therapies getting some level of activity. And then combining perhaps a PARP inhibitor with an IO. But what about just the PARP inhibitors just as an additional line of therapy? There's multiple companies now, just like there are multiple companies that have different IOs, there's multiple PARPs that are approved in other metastatic tumor sites. What should our colleagues be thinking about now to treat advanced prostate cancer? Right.
I think that, I mean, the discovery that some prostate cancer men have either germline or somatic DNA repair defects is really a big one. It's really hard to know what the exact proportion of these men is. And probably there are variations from countries to countries based on your genetic backgrounds, and also the way you're detecting that. Also, whether you're looking at monoallelic or biallelic abnormalities, generally speaking. So, but at least, the subject is on the table, and we know from the TOPARP phase 2 trial that at least one PARP inhibitor, olaparib, works. Also in patients, again, with very advanced disease. So as you said, there is intense research at the moment with PARP inhibitors alone, with many, many open questions. One is really, should we select? And maybe you don't need to select, actually, like in ovarian cancer, where we realized that actually you don't necessarily need to do that. In prostate, it's really something highly debated. Another question, obviously, is if we have to select, do we go for biallelic or monoallelic abnormalities? Another one is, are all these gene mutations or deletions the same, predicting the same? Most of these patients have BRCA2 mutations, but there's also ATM, CHEK2, many others. We don't really know at the moment whether they predict for the same degree of efficacy for these drugs as BRCA2 does, or BRCA1 more rarely. So all this really needs to be addressed because that's really important for drug development for patients to benefit. The good news is that, as you said, there is really currently intense research around that. I know probably 4 or 5 compounds currently under development in phase 2, but also in phase 3, trying to demonstrate their superiority versus standard of care, including in mostly actually in patients failing abiraterone or enzalutamide. So we can really expect more and more data. Probably every 6 months or so, we will get data to help us for our knowledge.
Yeah, it's such a great time to be in the field, not only doing the research, but also enrolling patients in these trials. It creates a tremendous amount of hope for so many patients. And it's really interesting that when we look at the IOs, the checkpoint inhibitors, we have this ongoing controversy of how important is it to have PD-L1 or PD-L ligand positivity or negativity? Is it an all-comer trial? Do we have selection? And likewise with the PARP trials, as you say, what is the role of biallelic, monoallelic, and what are the different genetic mutational changes that could inform therapeutic efficacy? So it's a great time, I think, as you're really masterfully pointing out the precision medicine goals that we all rather aim for, rather than throwing the kitchen sink at patients. But let me switch over in the last couple of minutes to an area that's also very exciting and different from the traditional AR pathway, and that is PSMA testing and also theragnostic implications. Maybe you'd like to talk about that.
Sure. So we knew PSMA for a while in prostate cancer, but until recently we were not really able to use this knowledge for either diagnosis or for treatment endpoints or goals. So this is a protein, a transmembrane protein that is expressed in most patients with advanced prostate cancer. So it's quite universal. So that's important, even if there is heterogeneity inter-patient, but also intra-patients from one metastasis to another one. But still, it's quite broadly there. So one obvious potential applications that we can do is PET scanning, and this is coming quite fast now. It's very, very likely that PET PSMA is the best imaging for prostate cancer men that we have so far. Better than PET choline, probably at least comparable or maybe better than whole body MRI, and for sure much better than the classical couple CT scan plus burn scan. So this is arriving quite soon, and actually this will, set a new field, because we will see much more than in the past, and we will have to adapt our current treatment according to new images. For example, if you do bone scan, CT scan, or other imaging, you see nothing. You do a PET scan, out of a sudden, it's becoming an oligometastatic disease. How do you treat? So there will be field for research regarding that. Now, perhaps even more important is PSMA as a potential target for treatment. The first data reported by the Germans, who were really probably the first to do that, and then the larger trial reported by the Australian is really compelling. Most patients, even in very advanced stages, when they were selected based on PSMA PET positive cancers, actually benefited from lutetium PSMA targeting. So I know that some companies are now running phase 3 trials, but there are also other ways perhaps to target PSMA, either with a different radioisotope using an alpha emitter such as actinium, or with something else, and this is also ongoing. So it's again a totally new field, which is really exciting.
Yeah. No, you summarized it very well, and it's taking off on sort of an organic basis. I think in Germany there's so many centers, but you made a very good point that we've got to do these phase 3 trials to really get the level 1 evidence and get some standardization about interpretation of just the PSMA scans. There's multiple different types. I think it's this whole novel next generation imaging is bringing in our nuclear medicine radiology colleagues along with us. So they're adding a lot of fertile opinion and controversy to the field. And then excitingly, this theragnostics, by bringing in a targeted alpha therapy, or in some cases even some beta particles, it really seeing some dramatic improvements in patients who've blown through multiple lines of approved therapies. So I think with that, I wish I had more time. Thanks for all that you're doing for advancing the field for patients, for the entire profession of medical oncology, urology, radiation oncology. Your leadership is essential. So thanks a lot. Thanks for taking your time out here at ASCO 2018.
Thank you very much, Neal.